One of the questions we're most frequently asked here at the Royal Vascular Institute is what are the complications of venography and of venous angioplasty. They're the same complications that we face when we use these techniques in other parts of the body. The first thing we like patients to understand is that venography and venous angioplasty are not new techniques. These are techniques that we've used as interventional radiologists in other parts of the body for many, many years with great success and with great clinical outcomes. The complications of venography involve the complications of getting to the vein that we want to look at and the complications of performing the venogram itself. Venogram is the word for pictures of the vein using contrast. It can be done with a catheter-based approach, which is what we do here at the Royal Vascular Institute, or it can be done with a non-invasive approach with either CT scan or MRI. We can write orders and prescribe CT scans and MRIs for patients who wish to obtain those procedures, but they're not performed here on site. The risks of venography, as I said, involve the approach to the vein, and then once we are in the vein, the risks associated with the venography itself. The risks of the approach to the vein involve basically bruising, which happens in less than 1% of patients at the level where we make the access. Typically that's at the groin level, because the vein at that level, the femoral vein, is the largest and the closest to the surface. We minimize that risk by using some minimally invasive techniques that we've perfected in other parts of the body. Very small tools are at our disposal, and we use imaging guidance to access the vein. Ultrasound is the preferred imaging guidance at this level. Once we have access to the vein, we guide the catheter, which I've showed you in other views, up through the highway of the body into the veins that we want to look at. The risks of passing through the veins themselves are minimal, but there is a small risk of blood clots forming. Veins are made to have blood only go through them, and they don't like to have anything else go through them. So the way we minimize that possible complication is by giving patients a blood thinner during the procedure intravenously. And that's a short-acting blood thinner that will wear off before the end of the procedure. Once we're in the vein that we want to take a picture of, for instance the jugular vein, we inject a contrast dye and take pictures of the vein using X-rays. The risks of that injection themselves are limited. However, it is a foreign material that we're injecting into the venous system, and there's a very small risk of allergic type reactions, similar to the risk that there would be of any other medicine causing allergic reactions. Once we have taken our pictures of the vein, the catheter is removed from the groin, and hemostasis, or a dry state, is achieved by holding pressure over the area that we've made our access. If we perform an angioplasty, there are some slightly increased additional risks. Obviously, we're going to perform a procedure that dilates the vein or opens up the vein, so there's a risk of damaging the vein. The big risk of that procedure is blood clot formation on the area of the vein that has been damaged by the balloon angioplasty. Again, we limit that risk by using blood thinners, both during the procedure and for a short period of time after the procedure. Finally, the risk of damage to the vein itself, if the vein were dilated to a point where the vein began small enough so that when we dilate it to the size it should be, the vein was either torn or ruptured. Sometimes that's a situation that we can manage by inflating a balloon in place, letting it stay there for a period of time while the patient's on the table, and then deflating the balloon once we've seen that there's flow through the system. One of the big benefits of working in the venous system is that it's a low pressure system, so controlling bleeding is much less of a problem with damaged blood vessels than it would be if we were working in the arterial system. Hopefully that helps.